Just want to welcome you all to the final session of the HITAP ADP webinar series on using evidence to address healthcare challenges in LMICs. Thank you for choosing to spend your morning or your afternoon or late evening with us. We really appreciate it. We have successfully completed, as of today, 2 previous webinars. And Alia, can I ask you to go to the next slide, please? 2 previous webinars, as you can see here, where we have traced the life cycle of a health technology. And today we're at the final stage of the implementation and M&E. So today I'd like to welcome our chair, who we're very delighted to have, Ms. Cecilia O, who is the program advisor with UNDP's HIV, Health and Development Group based at the UNDP Bangkok Regional Hub. Since 2014, she has coordinated the Access and Delivery Partnership, or ADP, as you've seen in our emails, a global project that is led by UNDP in collaboration with TDR, the WHO, PATH, and they are aimed at supporting health systems in low and middle income countries through strengthened institutions and human capacities. So without further ado, I'd like to introduce Cecilia and ask her to go through this session with us. Thank you.
Great. Thank you very much, Aparna, and a very warm welcome to all of you. And as Aparna has said, thank you so much for using your valuable time to spend it with us to learn a little bit more about the use of evidence in HTA and implementation. First of all, I'd like to well, obviously thank the HITAP team who have worked tirelessly behind the scenes to get this webinar, not just this one, but the third in a series of the HITAP ADP webinar series on knowledge exchange in the time of COVID-19. And I think what we'd like to do is to highlight to you that this is in a sense, a continuum of a webinar series that starts, first of all, to look at the identification and prioritization of health technologies, as Aparna has just mentioned. The second webinar was on procurement of health technologies and price negotiations. And now I think this is the culmination, and if you like, the climax of the webinar series where we're talking about the use of evidence. Let me just maybe start to sort of frame the objective of this webinar. And I think it really is to look at the use and the importance of the use of evidence in informing implementation. And this is crucial to ensure that resources, and often scarce resources, can be used optimally, and that maximum benefits can be derived from health technologies and health services so that these are accessible to people. And I think if we go to the next slide, we look at the very specific objectives of this particular webinar, the third one in the series. And there are actually 3. I think the idea is to communicate the importance of routine monitoring and evidence gathering to inform the implementation of health technologies and the introduction of health technologies. The second objective or aim is to highlight how evidence can improve the implementation and M&E of health technologies. And we will see this through the case studies, the very interesting case studies that we have in store for you. And then I think the third objective is really to look at the introduction of evidence use through real world implementation and M&E, as I said, from the various case studies from different parts of the world. And then finally, I think we should take the opportunity to reflect on how such evidence has been used in the current pandemic context. And I think this is really the key objective of these webinar series, to try to see how we can have information exchange and to benefit from country experiences in terms of what we're trying to do, how we're building systems to gather evidence and to use them, whilst we are in the grips of a pandemic. And I think this webinar and this webinar series is, I think, an important tool that we can all take advantage of. So maybe if you'll allow me, I'll very quickly go through the organization of this session. And the next slide will see that we have various, I guess, parts of this webinar. We know that we only have 2 hours, so we're trying to make optimal use of this time and yours. So we'll start off with a keynote address, and I'll introduce Dr. Suwit very shortly. Then we'll go through what I've mentioned before, the case studies, including the case studies in Bhutan, the Philippines, in Indonesia, and Thailand. And then I think we'll take a little break, just to give yourselves time to digest all this information, and we'll come back to a moderated panel discussion. Oops. And then finally, once we've had a vigorous question and answer session, and we hope that you will be satisfied with the answers and the responses that you get, we will close the session. But then we'll hope to be able to ask your ideas in terms of how we can continue sharing information and learning from each other. So that, I think, concludes basically a very quick introduction to this webinar. And I'd like now to introduce Dr. Suwit. It's always a pleasure for me to introduce Dr. Suwit Prasit. I think he is no stranger to many of us in the audience, but for those who have yet to the pleasure of knowing and meeting him, Dr. Suwit is now the Vice Chair of the International Health Policy Program Foundation, or the IHPF, and the Health Intervention and Technology Assessment Foundation, HITAP. He's also the chair of the Institute for the Development of Human Research Protection Foundation and the chair of the Health and Society Creation Foundation and the Asia Pacific Observatory on Health Systems. Many of you would know that prior to his retirement, you can see that even in his retirement, Dr. Suwit has kept himself very busy. But prior to his retirement, Dr. Suwit served as the highest government official in the Ministry of Public Health in Thailand as the Senior Advisor in Disease Control. So as I've said, Dr. Suwit is here to give us the keynote speech to start us off on this webinar series. So without delay, I will call on Dr. Suwit. Please, Dr. Suwit.
Thank you, Cecilia. Good afternoon, everyone. Indeed, this session is the key to success. Having a health technology included in the universal health coverage, which means people can have access to that health technology, is just the beginning. That decision is just the beginning. It will end only when the patient, the people have real access and have improvement in their health status after using that health technologies. And that's what we care for in today's session. I'm sure you all know very well the policy decision process is a circle, starting with agenda setting, policy formulation and decision, and policy implementation, and then monitoring and evaluation. It doesn't mean that agenda setting is the starting point. It's a circle. It can start from any place. If you monitor and evaluate something, and you found with evidence that you need to change the decision, then you move for an agenda setting, and then policy reformulation and new decision, and implementation of the new decision. So it's a cycle. It's a cycle. It's a circle. It's not a linear, serial type of activities. Now, if you are involved long enough in implementing policy decision, you would agree with me that policy formulation and planning and even decision is like a sweet dream. You formulate, you make decision, and you want things to happen well, like what you want. That's like a sweet dream. But when you go to implementation is hard work. You have to overcome so many barriers to make your dream comes true. And when it goes to monitoring and evaluation, it's like being tortured. You feel down, you feel bad when you learn that what you want does not achieve well or does not progress well. So policy decision or planning is a sweet dream. Implementation is hard work. And monitoring and evaluation is like being tortured. These are the key message that I would like to deliver to you today. If you don't want to work too hard in implementation, if you don't want to be tortured when it comes to monitoring evaluation, it's unavoidable that you need to prepare well from the start, from formulating the decision based on real good evidence. And I would like to reiterate that when we talk about evidence, most people only think about experimental evidence. That is the evidence generated from research, from systematic research, from systematic review. But as important as experimental evidence is experiential evidence, the evidence generated from the experience, from the real life, from what you see, from what you have been through in your life, in your working life, on the ground. Sometimes, particularly those who do health technology assessment, you sit in the air-conditioned room, collect all secondary data, and then put into certain formula, and then come out the cost effectiveness or incremental cost effectiveness ratio, budget impact, whatever. These are an example of experimental evidence. But experiential evidence is something that you really face when you go to real life. Now you need both of them. The third point that I would like to share with you is the evidence for implementation. When you go to implement, for example, when you have a health technology agree, for example, we agree to include renal replacement therapy into our universal health coverage, which include hemodialysis, peritoneal dialysis, kidney transplant. How are we going to develop the service? How are we going to get the services to the people? And how are we going to provide financial support for the people to receive the service to the service provider? How are we going to deliver the peritoneal dialysis solution to the people? Do they have to come to the hospital or health center every week and then carry home very heavy loads of peritoneal dialysis solution? Can we deliver it to their home We have so many logistic companies deliver home delivery services available. These are not health services, but they are things that we need to consider when we implement. And you need evidence to make sure that these things can be delivered effectively. So you need evidence for service development, building facilities, getting equipment. The second session you have on procurement, right? That's getting the equipment and drugs, and develop adequate human resource. For the example that I just mentioned, renal replacement therapy, you need doctors who can do kidney transplant. You need facilities for hemodialysis. If you have, like in Thailand, peritoneal dialysis, first policy means every patient that needs renal replacement therapy has to go first to peritoneal dialysis. You need peritoneal dialysis nurse. You need dialysis nurse. You need to train them. These are the evidence that you need for implementation. How many dialysis nurses that you need to train? Where should they be placed all around the country? How much you are going to remunerate them to ensure that enough incentive for them to perform well. So these are the example of evidences that you need for implementation, for good implementation. There are also evidences. How are you going to ensure the satisfaction of the people to your services? How are you going to ensure that they receive the service regularly? These are all evidence for implementation. That's why I said implementation is hard work. Don't stop at just sweet dream. You cannot. Economic evaluator usually stop at sweet dream. Make sure that your research is used for decision making to include the health technology into the benefit package, or someone pay for the health technology. And that's all. I strongly urge that economic evaluator or health technology assessment expert should join in to the implementation process through the implementation research. Implementation research will generate evidence to improve implementation. And also join in my last point, the monitoring and evaluation process. The monitoring and evaluation research in order to generate evidence to feed back to decision making. Let me give you another example. During the, actually right before the COVID, our universal health, universal coverage system has formulated a policy to reduce the congestion at the hospital, the crowded hospital. One of the policy options is to ask the patient, to allow the people to receive drugs from a pharmacy near home. So when they finish with the examination, they just get the prescription and go to pharmacy near home and get the drug. Or if they are a chronic patient, instead of coming to the hospital every month or two, they may come to the hospital only every 6 months. And the rest, they can refill their drugs at the pharmacy. When we start to implement, even before we start to implement, we ask economic evaluation expert to join into monitoring evaluation. they have to collect many data to inform us the progress of the implementation. They have to go into the field to visit the hospital, to visit the pharmacies, and talk to people there who work there, talk to patients who receive the service, to assess how good the services are and how the systems work, how the financial reimbursement system work, and finally summarize, synthesize, and propose back to change the decision. For example, we started with providing financial support to hospitals based on number of pharmacies that are in that system. And we found that there are so many pharmacies get into the system through the hospital, but only a few pharmacies really dispense the drug. The rest get very little or very few prescription to fill the drug. And the evaluator proposed that we should change the financial support system to the hospital instead of based on number of pharmacies in their network, but based on prescription, number of prescription instead. If they put out a higher number of prescription, they get more financial support. These are good example of monitoring evaluation. They also collect the cost data from pharmacies and allow us to remunerate the pharmacies better. So pharmacists are at the pharmacy, private pharmacies, are more happier to deliver or to dispense the drugs because they now get remunerated in a fairer rate, financial rate. These are examples of using evidence for implementation and monitoring and evaluation. Finally, I would like to reiterate to you that evidence is like knowledge. Knowledge is of the past. Wisdom is for the future. So when you collect the evidence, you are creating knowledge. You are creating knowledge. You have to synthesize not only the knowledge you generate, but the knowledge from somewhere else into wisdom for future improvement to ensure that the people really get the services from that health technology and people really improve their health, really improve from your decision, your proposal to decide to put that health technology into the system. Thank you so much, Cecilia. Thank you so much, everyone. I wish you all the success in this session, but most important is to wish you all the success in getting the right health technology to the right people in the right place and the right time to improve their health, their quality of life, and to make sure that they will not face catastrophic health expenditure or medical poverty. Thank you. Have a nice afternoon.
Thank you very much, Dr. Stewart. As usual, words of wisdom from yourself. I think it is my duty, and a very daunting one at that, is to attempt a 60-second summary of what you've just said. I'm not going to make a pretense that I will get it all, but I think your main message to all of us is that it is extremely important that we have an understanding of the need for systematic evidence gathering and monitoring that will inform you know, the whole process of our decision making, right from the time of whether it's selection and introduction to the time of implementation, to the time of reassessment, and as well as, you know, to help us make decisions about whether change of a previous decision is necessary. So I think your message, your second point is that, you know, as we make decisions about universal health coverage and, you know, what that health package will encompass, that is, in your words, a sweet dream, because the next stage is, you know, making that sweet dream a reality. And again, in your words, that is something that is extremely hard and that needs good preparation. And that goes back to, you know, the point again that good evidence is necessary. And what you were also saying was that all kinds of evidence is necessary. So not just the research or experimental evidence, but the experiential evidence is equally important. And also evidence from implementation research is key to help us understand what are all the different factors that will come into play in terms of, you know, the implementation of health service or health technology. And I think, you know, at the end of the day, the idea would be that, you know, the health technology assessment process is essentially being able to understand the different parts of a system that needs to be put in place to ensure that there is routine monitoring and evidence gathering, so that we are continually able to assess our decisions, you know, from end to end. And I believe that that is the key message that you're giving us. And in a sense, that is the why this particular webinar is important, you know, and it's important for us to consider the reasons. I hope, Dr. Soit, that that was an adequate representation of the message that you were trying to give us.
Cecilia, actually, I should speak to you first, and then let you address the audience. Instead of spending my 15 minutes, you spend just 1 minute and do just about the same thing. Thank you so much.
Thank you, Dr. Soit. This is the point about what you said, knowledge is the past, and using that knowledge becomes wisdom for the future. I'm doing exactly what you asked us to do. But again, thank you. And I think this is now time for us to go to the next part of the webinar. We've sort of understood or listened to the why it's important to look at evidence, to monitor, and to look at evidence use. Now I think it's time for us to look at the how that can be done. And here we are reliant on our, you know, our eminent panel of speakers to show us how that's been done in their respective countries. And I'm very pleased to be able to introduce to you our panel of speakers. So let me start off by first introducing Mrs. Deepika Adhikari. Mrs. Deepika has a bachelor's degree in bioinformatics and has been working in the Ministry of Health in Bhutan for the past 10 years. She's responsible for HTA under the Essential Medicines and Technology Division, and is currently one of the COVID-19 media focal points, who is trying to make risk communications effective during the COVID-19 or for the COVID-19 response in Bhutan. So Deepika, if I could ask you to start your presentation, you will now have 10 to 12 minutes. Thank you very much.
Thank you, Cecilia. Good morning, good afternoon, good evening, everyone. I'm Deepika from Bhutan. Thank you for introducing me. For those who are not familiar with the country Bhutan, we are a country situated in between India and China. It's a very small country. We only have a population of 700,000 people, and our GDP is a little over 3,000 USD per capita. And we have been partnering with HITAP for quite a long time, almost 7 years. I think it started in 2013. And I am a HTA researcher, and I'm not really involved in the implementation part of the PCV, but this presentation that I'm going to make today is very much in consultation with the program that looks after the implementation. We have a program named Vaccine Preventable Disease Program. So to proceed with my slide, can you move to the next slide, please? Okay. So evidence use in Bhutan, in the Bhutanese healthcare system, we do it mostly for the pre-introduction decision-making part. So we use evidence to introduce new health technologies in Bhutan. And PCV is one of the first, I think it's the first in the history of Bhutan decision taken using evidence. We had done a thorough HTA study. And for the implementation part, yes, we do use evidence, but it's not in a very coordinated manner. We haven't done any research, or we don't follow any protocol as such to use this evidence in implementation. However, we do use. Now to come to the immunization implementation part of Bhutan, we have some salient features. Can you move to the next slide, please? Okay. So in Bhutan, coverage of vaccine is 95%. We have maintained it at 95%. At times it even goes up to around 98% as well. And all of this has been possible because we have some very good conducive factors. For example, I have cited 4 over there. First one is we don't have any private pharmacies selling vaccines. So that automatically brings the population to the health facilities, the public health facilities. And also we do not have any private practices. We do not have private hospitals. We only have private diagnostic centers. So that is one very good conducive factor for bringing our coverage very high, up to 95% on an average every year. Then we have a very good cold chain system that goes even to the remotest part of the country. And third, vaccination is being provided by trained health workers. We call them HA here. H is for health, A is for assistant. So they are like paramedics. So they are the ones who usually man the remotest part of remotest health facilities. So they are properly trained people, clinically aware and sound. So they are the ones who vaccinate the people. So they go for outreach clinic duties. So they visit the villages, schools, and vaccinate the students and even the people in the villages. So that is there. We don't have vaccinators. So people, even the coverage is good because people even come to the health workers. They have a good trust over them. Even they come to the health workers even for other problems they might be having, health related problems. So while they come for that, the health education is also provided, and vaccination and even other public health activities are also conducted in the locality by the health worker. And the fourth is we have a good district health information system. This is an online system where all the districts, they submit monthly report in this system, and it all comes to the Ministry of Health here in the capital of Bhutan, Thimphu. So that is very well monitored, and interventions are taken after analyzing the report from the district health information system. And we also try to make interventions for those districts that are performing low in terms of coverage, and sometimes there might be underreporting or wrong reporting. Those are also rectified through the system, and we also try to find out the wastage information from the system. Thank you. Next slide. So I would like to cite a short example here. The delivery of HPV vaccine, the coverage was 95.3% even during the pandemic for Bhutan. And this was possible because of the same conducive factors I talked about that time. And also with the help of the Ministry of Education, because this time during the pandemic, because the schools were closed, we collaborated with Ministry of Education to contact all the teachers, the class teachers in the remotest part of the school, to inform the girls about the benefits of getting vaccinated, HPV vaccine. And also we took their help to communicate with the students and then to bring them to a site where we could vaccinate them. So this was one very good example that we could maintain the coverage rate even during the pandemic. Next slide, please. Okay, the types of data we have in Bhutan. So I'll start with the core, that is reporting. So we have, like what I said, the DHIS2, that is the online platform where all the districts report monthly. That is done by all the districts and it comes centrally to the Ministry of Health and we analyze the data. Second, we have is vertical reporting. Vertical reporting meaning the vaccines that are not delivered on a daily basis. For example, the flu vaccine, it's a seasonal vaccine. So flu vaccine is delivered once in a year. So the data for it is reported vertically. That means the health workers, they report directly to the program. They don't put it in the system. What goes in the system are those vaccines that are delivered on a daily basis. So for example, a child completes 6 weeks this week, then next week there'll be more children completing 6 weeks of vaccination. So that goes into the system, but for vertical reporting, it's either the seasonal vaccines or vaccines that are given one time like HPV. Then we have the annual household survey data. So annually, the health workers in the remotest part of the country, they visit the households. It's like a census survey. So they collect information about health of the people. And so that is collected and it comes to the annual health bulletin. We have a document which comes out annually. It's called annual health bulletin. Then we take information from the population data as well to calculate the number of vaccines to be procured next year. So we try to estimate the projected population. Then next we have is the national health surveys, which are conducted every 5 years, I think. So that validates the coverage that we try to estimate every year. So it's done, I think, every 5 years. Next, please. Next slide. Okay. So benefits of external support, we have conducted 2 studies. One is the PCV study and one is the recent rotavirus vaccine study in collaboration with HITAP and IDSI. And it has been very well accepted by the doctors here. They appreciate the design of the study and that we have taken a holistic approach. And we have tried to develop our capacity by learning and doing method with these 2 projects. But however, collaboration will greatly help in the future as well, not just to perform the studies, but also for networking and there are other benefits as well. Next, please. Next slide. Okay, next slide. Going to the PCV implementation. The study, the HTAC study was conducted in 2017 and in 2019, the implementation. We took about a year to do the procurement and adjusting everything else. So it's the first HTA informed decision in Bhutan. And then in between, we also we had an application for PCV for elderly, which came in 2019, but right now due to the pandemic, that's on halt. Next page, next slide. Okay, the current coverage in 2019, the coverage for PCV vaccine was just 26%. That happened because we found it out only later, that is early 2020, we found it out that there was underreporting of data because we couldn't incorporate the elements for PCV reporting in our system. It wasn't incorporated well. And also, because it was a new vaccine, there was delay in implementation in some of the health facilities. So that's why the coverage was low in 2019. So we made intervention after analyzing the data. And now in 2014 so far, 2020 so far, we have 74% coverage. And we had taken the proxy of the DTP, the pentavalent in our study, but it could not be implemented the same in the first year of implementation. But now 74% coverage so far, meaning 75% of the year we have already covered. So rest of the year, I think we should be able to catch up to over 90%. Next slide, please. Okay, the challenge is we have the resource constraint is generic. Everybody might be having the same problem. Coming to data bias, in our annual health bulletin, the OPD part of the Apex hospital in Bhutan, we have a national referral hospital in Bhutan, in Thimphu. That OPD part is not covered. That is one major challenge for us. So our data might be biased when we do the studies. And we don't have real-time data, although we have real-world data, but the data that we use are usually from the past year. So we are not able to use the current data to make our estimations. Then next we depend heavily on the international organization procurement system. We use the UNICEF procurement system to procure most of our vaccines. And also we go by the WHO pre-qualified products. So it's a gray area where I won't really call it a challenge. It may be an opportunity as well, because it helps us to get the vaccines, because Bhutan being a very less populated country, it's difficult for us to get the vaccines. So we rely on the international organization because they do pool procurement and procure vaccine for multiple countries. And the other one major problem, a challenge we have is we do not have direct contact with the manufacturers. So we deal through the dealers in between, suppliers. So price comparison and price negotiation is always an issue for us. Next slide, please. Yeah, so this is my last slide. If the pandemic continues, vaccine coverage will again be an issue, but we are putting together every possible means to achieve the target. And hopefully, if everything goes well, in 2021, we intend to do a post-introduction evaluation of PCV. Thank you. Oh, I had one more slide, sorry. The lessons learned from the PCV implementation is that coverage assumption do not always go as planned, like what Dr. Suvit said. It's a very nice dream, but when we actually try to implement, there were some implementation issues. Whole chain management is the key to delivering vaccines, and vaccine reporting could be done in multiple ways, like what I mentioned before, the vertical reporting system and in the online platform. And then we also realized that dropout usually happens when there is a long gap between the schedules, meaning if the gap is low, like 6 weeks to 14 weeks, the dropout rate is less, but the third schedule, when it goes to 9 months later, then the dropout is usually high. So these are the lessons learned from the PCV implementation in Bhutan. Thank you.
Thank you so much, Deepika. That was a very instructive sharing of the country experience, as well as the findings of the HTA study for the PCV vaccine in Bhutan. I think you illustrate very well the need for evidence, and it's a continual process. So thank you again. And I know that there will be questions for you, so I encourage the audience to type in their questions into the chat box, and we will collate them and then have them forwarded to you at a later stage for your response. But in the interest of time, I'd like to go to the next presentation. And now it's my pleasure to introduce Ms. Jamaica Briones. Jamaica is going to be looking at the reassessment of the PCV vaccine in the Philippines. Now there's a tie connection here because Jamaica finished her master's degree on HTA at the Mahidol University prior to joining the Department of Health in the Philippines. She obtained her pharmacy degree at the University of Philippines in Manila. So as you know then, Jamaica is a pharmacist by background, and one of her first major tasks at the HTA unit at the DOH in the Philippines was to lead the study on the PCV reassessment. So I think there is no better person than Jamaica herself to give us this next presentation. So please, Jamaica, the floor is yours. Thank you.
Thank you as well, Cecilia. I hope everyone could hear me clearly. So Also, thank you again for HITAP and ATP for the opportunity to share today. So good day, everyone. I am Jamaica, and on behalf of the Department of Health Philippines, I am going to present the Philippine reassessment of the pneumococcal conjugate vaccine. So next slide, please. So for the outline of my presentation, I will begin with a background on the HTA landscape and the country, the rationale for the PCV reassessment, conclusion of the study, decision and next steps and learnings. So next slide. So for a very brief background for the HTA landscape and the country, the Philippines has experienced a 50-year process of health reform under different names. The UHC law is the culmination of decades of progress. Although HTA has its beginnings since 1998, the signing of the UHC Act last February 2019 clearly outlines the mechanism of HTA. This paved the way for the progressive realization of the fundamentals for HTA institutionalization, such as the series of capacity building activities and the creation of the governing body, which is the HTA Council. So next slide. To officialize the provisions crucial to the HTA process, an administrative order on the new implementing guidelines on HTA was created to provide guidance towards the purchase and coverage of health technologies in support of the UHC. This AO includes the HTA process and methods guide to detail the processes and methods governing the conduct of HTA, which is used as basis by the HTA Council in providing recommendations to decision makers. So next slide. So the PCV reassessment was triggered upon the request of the National Immunization Program last January. The study took an 8-month timeline in total, and aside from gathering evidence on the clinical, economic, as well as ethical, legal, social, and health systems implications, so that's LSHI for short, a public consultation, which is an inherent activity in the general process of HTA, was also done to address different queries coming from stakeholders. After comments from stakeholders were considered by the HTA Council, the initial recommendation was posted online and sent to stakeholders as a part of the appeal process, after which the appeals were again processed, and by the end of July, a final recommendation was made by our HTA Council. And this was elevated to the Secretary of Health, where he made the final decision last August. So next slide. Aside from the request of the immunization program, the following are the reasons why we performed a reassessment. So first, there was the presence of new clinical evidence on the 2 vaccines. Second, there was a new price quotation given by the 2 proponents, and there's also an available new preparation with this, which is the multi-dose vials. So previously, the immunization program was using single-dose vials. And lastly, the intent to expand vaccination coverage, since currently PCV is just implemented in selected regions in the country with approximately 30 to 60% coverage depending on the region. Next slide. So the issue of which PCV to use has been a long-withstanding question in the country. So based on the cost effectiveness and budget impact study last 2013, the PCV-13 was used as part of the expanded program on immunization in selected regions starting 2015. Concurrent with finalizing the guidelines, the Council began fulfilling its mandate to answer the policy question on various health technologies, including PCV. Following the newly minted HTA methods guideline, our PCV reassessment for 2020 answered the research questions on efficacy through a rapid review, good value for money through a cost-utility analysis, budget implication through budget impact analysis, the LSHI through online surveys, interviews, and also various consultations from stakeholders. So as HTA evolves in the Philippines, the more that we realize the importance of not only performing economic evaluations for coverage decisions, but also the essence of additional domains such as LSHI that is critical to make a well-considered decision on implementation. So next slide. Our research questions were anchored to answer the HTA decision framework in accordance with the provisions of the Universal Healthcare Law. The decision framework involves answering questions regarding the following 5 domains, which are effectiveness and safety, cost effectiveness, affordability and viability, household financial impact, and responsiveness to magnitude, severity, and equity. So, using the decision framework presented, the HTA Council's main points for recommendation are the following. So first, they recommend the use of a multi-dose vial. Second, they recommended a vaccine indicated for minimum serotypes, which is specified in the document, where both PCV10 and PCV13 are qualified. And lastly, they recommend a competitive tendering process to ensure equity, affordability, and universal vaccine coverage. So aside from that, the Council has also highlighted in their recommendation the further need actually for surveillance and research, which are essential for feedback on the implementation, such as program evaluation to measure impact of burden of disease, periodic surveys to characterize changes in serotype distribution, surveillance for impact monitoring and assessment, and lastly is clinical and economic burden studies of pneumococcal diseases. So I think the slide is, next slide please. Oh, they are missing 2 of my final slides. Should I just continue and share? Oh, I think I'll just say what I have to say. I think it's fine. So after the decision was made by the Secretary of Health, based on the HTA Council submitted evidence, we did a series of information dissemination, and it was done via posting on the Philippine HTA website, and emphasizing in our HTA process, only positive Council recommendation can be decided upon the Secretary of Health, and he cannot overturn negative recommendations. And currently, as of now, PCV is undergoing a full procurement process by the government. So next is again implementation and monitoring of the vaccination program by different POH programs. So in summary, for the learnings that we had in this reassessment, so first I highlight that given that the UHC is a political choice, this makes the conduct of HTA work a political choice as well. The success of HTA, like any other enacted policies, will surely depend on political support and leadership. Second is the HTA institutionalization is a tapestry of solutions composed of many threads. An overview of the salient steps, including HTA Council creation and of course the officialization of the processes and methods, were just a few of the many things that were done. And third, PCV reassessment was an opportunity to test our draft processes and methods, and challenges in conducting an assessment were evident. And the biggest challenge was the availability of data actually, which just really points out that there's just so much work to do in this field. And lastly, we have seen the importance of the role of our HTA Council in this assessment. Stepping back from the political deliberations, our council served as the steady voice to provide objective and technical recommendation for the determination of entitlements to all Filipinos on which policy decisions should be made. I'm sorry for the last 2 slides. It was not flashed, but I hope everyone learned something from us today, and that ends my presentation. So thank you all for listening. Maraming salamat po.
Jamaica, thank you so much for that presentation. We will make sure that the last two slides, including the slide on the lessons learned, be included in the final slide package. And apologies for that. But I think you did a really wonderful job in, sort of summarizing the lessons learned from that process of the PCV reassessment. And I think you also pointed out to the fact that, not just the fact that it is a political, sort of framework and decision making, that also will help in terms of the success of HTA and evaluations. And I think that the one point that you also made in terms of lessons learned is the governance structure, that having an HTA council that is supportive of evidence gathering and the good use of evidence is an important one. So I think that is instructive, for all of us. So thank you again for that wonderful presentation. I'm also going to note that there are also questions coming in from the audience. I know that Deepika has been answering them, and I will not doubt that there will be questions for you too, Jamaica. So please, we encourage you to respond. And for those questions that do not get a response as of now, we will revisit them during the panel. But without further delay, I want to go to the third presentation, which is the case study from Indonesia, which looks at incorporating evidence into implementation of healthcare technologies in the country. And our presenter this time is Dr. Aulia Suwantika. And Dr. Aulia is a lecturer and researcher at Universitas Pajajaran in Indonesia since 2015. And more recently, he has taken on other roles, including consulting with the Clinton Health Access Initiative in Indonesia, serving as a health economist on the Indonesian Technical Advisory Group on Immunization. And he's also a member of the National Drought Formulary Committee since earlier this year. So without further delay, I'd like to invite Dr. Aulia to make your presentation. Please, Dr. Aulia, the floor is yours.
Thank you, Dr. Cecilia, for the introduction. So at this occasion, I would like to share our experience on incorporating evidence into implementation of healthcare technologies in Indonesia by using PCV introduction as a reference case. Next slide, please. Yeah, so let me start from the current situation regarding the implementation of real-world evidence in Indonesia. So yeah, the current situation is healthcare facilities, government at the central and local level and national insurance at this moment already have several web platform development, and also there are several data warehouses that these healthcare facilities, the government and national insurance already have. But the challenge is about the utilization of this data. So I think in the future we have to major challenge to implement real-world evidence or to get real-world data in Indonesia. The first challenge is about data integration and linking, and the second challenge is about how to analyze this integrated data or linkage data to conduct several studies, for instance, outcome research, health technology assessment, and epidemiology and drug safety. So yeah, this is two major challenges that we are facing at this moment. Next slide, please. Okay. Yeah, as we know that WHO has encouraged the implementation of PCV vaccine in the national immunization programs, specifically in countries with high prevalence of pneumonia, such as Indonesia. Up to now, we have not included PCV immunization into the national immunization program for the nationwide vaccination. But since 2017, we have conducted pilot study. We have PCV has been introduced in to districts West and East Lombok that were considered as districts with the highest prevalence of pneumonia in Indonesia. Since 2017, the government decided to introduce PCV 13 instead of PCV 10. They used the evidence on a study about serotype prevalence, and then PCV 13. The study concluded that PCV 13 is considered to be more suitable to be implemented in Indonesia than PCV 10, according to the seroprevalence, according to the serotype prevalence. Next slide, please. Yeah. As I mentioned before, that this pilot study has been started in 2017, but after the pilot study, an evidence-based analysis was required to guide the policymakers in decision making to support PCV as part of national immunization program. So at that moment, there is a need that can be used as an evidence for the stakeholder on making stepwise on the introduction of PCV vaccination. So at that moment, we collaborated with Ministry of Health and several partners to conduct economic burden estimation, and then continue with cost effectiveness and budget impact analysis. So at that moment, we compared to available vaccines in the market, PCV 10 and PCV 13, and specifically we compare to vaccine pricing scenarios, UNICEF and market price. For your information, at that moment, the government through the Ministry of Health has already signed a contract with one vaccine manufacturer. And at that moment, because of regulation barrier, we were not allowed to purchase vaccine through international donors such as UNICEF and other international donors. So, yeah, that's the situation at that moment. But in this study, we specifically compare two alternative pricing scenarios. Next slide, please. Yeah. So, which data can be used in terms of real-world data? So, using this study as a reference case, if real-world evidence was defined as data that are collected outside the constraints of conventional randomized control trials, so in this to support this study, we collected real-world data in several approaches. So, the first, we conduct data from health profile, from national health profile. This national health profile is collected every year, and then every district, every province has to make a report to be delivered to the national level. So we can access this health profile from district, province, and national level. And then another data that can be obtained is hospital administrative data. As I mentioned before at the beginning of the presentation, that at this moment we already have several platforms, several data warehouses at healthcare facilities such as hospital. But again, there is no linkage between these healthcare facilities. So yeah, hospital administrative data, we collect data in this cost effectiveness and budget impact analysis. And then another data that we get is from claim databases. As you already may know, that since 2014 we started social insurance under BPJS Kesehatan as the provider. So since that, and then we can obtain, we can collect claim databases from the data warehouse. And then another approach that we can get is through the survey data. So yeah, for instance, national from the basic health survey, which was conducted every 5 years. And then we also highlighted two potential sources of data that in the future we can obtain. The first is about mobile health. If it can be integrated with the health record to monitor disease treatment, so I think this data will be beneficial for stakeholders or for researchers to conduct economic evaluation studies. And then social media as a quick and expensive way to gather large-scale real-world data. I think in a country with the large number of internet users, such as Indonesia, this can be potential. Next slide, please. Yeah, in this slide, I would like to highlight the result of our economic evaluation and budget impact analysis. So yeah, comparing PCV 10 and PCV 13, and we also specifically compare UNICEF and government contract price. The result concluded that PCV vaccination can be considered as a highly cost-effective intervention to be implemented in Indonesia. But the cost-effectiveness value of PCV 13 was reported to be better than PCV 10. And then in terms of comparing UNICEF and a contract price, in this slide we can see that applying UNICEF price for PCV 13, there is a huge gap in terms of budget required for the PCV vaccination. So in this in our study, we provided several scenarios for the government. The first scenario is the best scenario. We targeted 2021. The government can implement nationwide. So the graph in this slide is about the best scenario. And then another scenario that we took into account, we also applied moderate scenario when the nationwide can be implemented in 2024 instead of 2021. And then the worst scenario, we applied that the nationwide vaccination even cannot be implemented until 2024. So yeah, there is a significant gap between the UNICEF price and the contract price. So the gap means that if we apply UNICEF price, there will be more procurement budget, and then there will be more additional doses that doses, and then there will be more immunized children. There will be more affected cases, and there will be more self-treatment costs. Yeah, because the gap is very huge between UNICEF and contract price. Next slide, please. Yeah, once we finish the cost effectiveness and the budget impact analysis with several scenarios, and then we discussed with the Ministry of Health because we provided 3 scenarios, and then we agreed to apply the moderate scenarios when the nationwide vaccination will be implemented in 2024. So to expand the result of the study, we then took the potential impact of switch options into account. So we compare several available vaccines in the market. In general, we would like to compare the use of the potential impact of switch options on multi-dose into multi-dose, single dose into multi-dose. So we compare PCV 13 with PCV 10A and PCV 10B because, yeah, we at this moment there are already 2 PCV 10 vaccines in the market. So yeah, in this slide we estimated the potential vaccine cost. And in terms of cold chain costs for all scenarios in terms of available products in the the market. So we estimated the total saving in terms of vaccine and cold chain costs. Yeah, as I mentioned before at the beginning of my presentation, that the reason why we compare to vaccine to price scenarios, because at that moment there was a regulation barrier to achieve UNICEF or a Gavi advanced market commitment. But after we finished our study, and then we presented the result of our study to all stakeholders involved, and then the government decided to change the regulation. So since that, there is an access to purchase vaccines through advanced market commitment. So the government has committed in proceeding with the special mechanism for PCV procurement through Gavi IMC. Next slide, please. Yeah, following the same approach, and then Indonesia has signed agreement with UNICEF on COVID-19 vaccine procurement, because the government has changed the regulation since the PCV introduction. And then next slide, please. Yeah, this is my final slide. Lessons learned that I can share. The first is, it is necessary to link and integrate all available data warehouses and platforms from healthcare facilities, government, and national insurance. Yeah, and then the second one, by planning ahead, stakeholders can embrace big data and ensure the information they collect is accurate and consistent, allowing for a stronger and more resilient decision-making process. So in the future, if we already have more integrated and more integrated data, I think it will be more beneficial for the stakeholder to conduct monitoring and evaluation for all healthcare intervention. Thank you.
Terima kasih, Dr. Alia. I think, again, that's a very instructive presentation. I think we've, sort of gone through HTA, pre-introduction, HTA reassessment, and then now in the case of Indonesia, it's evaluating the options for switching from single to multi-dose PCV vaccines. And I think what is key in terms of your presentation is also to be looking at, the sources of data. I think where there is no routine evidence gathering, it is very important to be able to identify the various sources of data so that you can actually make a start. And I think it's also, you've given us, a lot of information on how that's done in Indonesia, and also in terms of future sources of data, which is very interesting, social media and mHealth. And I think that's something that, we might all want to be thinking about further. So thank you very much for that presentation, Dr. Alia. And again, please engage with the chat box, because I'm sure that there will be questions for you. And now we turn to the fourth and final presentation in the series, and we come back to Bangkok, and we have two presenters here, and I will introduce them. But what they will be doing in their presentation is to be looking at, the using of data in terms of high-cost users to help in decision making. So we have Dr. Wan Rudy Isaranuwachai, who is the program leader and senior researcher at HITAP. Now, for those who don't know Dr. Wan Rudy, she's also an affiliated scientist at the St. Michael's Hospital and an assistant professor at the Institute of Health Policy Management and Evaluation at the University of Toronto. And I think, we know that her research has focused on the application of health economics and health technology assessment in real world settings. And I believe many of you would probably have experienced and benefited from her contributions in HTA trainings from across Asia, Africa, as well as North America. And then the second speaker, Dr. Rukmani Bhutan. She's also a researcher at HITAP. And I think Dr. Rukmani has a very interesting career evolution. She graduated with a degree in physics from the Faculty of Sciences at the Khon Kaen University, and after which she worked as a research assistant at the Department of Health Research Project and Coordination, in Thailand, where she became interested in statistics. at which point she pursued a master's degree in statistics at the Kasetsart University. And it's no surprise that she is now a valued member of the HITAP team. So I will ask Dr. Wanrudi and Dr. Romani to take the floor, please, for your presentation. Thank you.
Thank you, Cecilia, for a very, very kind introduction and for everyone for joining. So I'll start off and then we'll pass on to Dr. Rakmani to finish up. Building on from the many great presentation, I like now to perhaps share with you a quotation from a gentleman named Joe Girard. He actually a car salesman and he holds a Guinness World Record in selling the most car in 1 year. He sold almost 1,500 cars. So that's about 4 cars in a day, every day. Now I am paraphrasing, but one of the things he said was, we should look back in order to learn and plan forward. And I think this quote resonates quite a bit when we think about monitoring and evaluation. And so when we think about what the case study that Dr. Rakmani and myself, we're going to share with you shortly, we like to look back and look at the data that we already have and see what happened and how can we use those to help us plan forward. We are going to be using existing database to identify high-cost user. And our subtitle is really what I think is nicely capture what we're trying to do, which is the search for those in need. Next slide, please. Now the concept of high-cost user, many of us, all of us are familiar with. It's a concept around frequent flyer or user. I know right now we cannot use any miles. Hopefully one day we'll be able to use them again. But this type of program created because they actually want to learn better about people who are using their services. In other words, the company, or the organization, they like to learn more about what can we do to serve this frequent user, this high user better, right? Now, what we're going to be talking about is going to be similar, but going in the opposite direction. Because unlike this company who like people to come back, for us, we actually don't. We want to ensure that we give people, like what Dr. Suvit said, provide the right technology to the right patient at the right place and at the right time. And then we hope they stay healthy. But in order for us to do that, it would also still be helpful for us to know who they are. So next slide, please. Yes, now this work is only possible because of our collaborators at National Health Security Office at HITAP under the supervision of Dr. Yot, and at the National University of Singapore, our colleague there as well. Next slide, please. Okay. So this is what I'll be talking about in general. We already started talking a little bit about the rationale. Next slide, please. This phenomenon that we want to call high-cost user phenomenon is not new. Many countries have experienced it, but mainly what this is saying is that when you look at people who are using health services, there's a small group of people who actually are using a big chunk of healthcare expenditure or healthcare resources. So we want to identify who they are. Now, like I mentioned, many countries, many of them are in high income area and they found it. So the question we had when we set out this journey was, does that also exist in Thailand? And if yes, what can we do about it? So first step, does that exist in Thailand? That kind of highlight, if we know who are using a lot of our services, maybe we can come up with way to better respond to that need. Next slide, please. So we are hoping that the study finding here, and we are continuing to collaborate with policymakers that can be used to help us learn more about people access to medicine for existing program. We also have a program specifically for high cost medication. We have not included them in this analysis, but that is one of the next steps that we want to take this similar analysis to. So we are going to build on from this existing work, and we hope that what the finding here can help us identify who have potential to be high cost user. And most importantly, these are examples of how we can use existing data to answer policy relevant questions. Next slide, please. So I'm gonna finish by talking a little bit about data. You heard a lot about the data, and perhaps I can throw the question to everyone, and please just use the chat bot to answer. In 1 minute around the world, how many emails that you think are being sent? In 1 minute around the world, how many emails you think people are sending? Please feel free to share your thought in the group chat bot while I continue to talk. Data come in different size of form. Can you click one more, please? It's the same slide, but yeah. So the size of the data is represent many things, right? Now I start to get 1 terabyte, 1 specified 500K. So you are saying that in 1 minute around the world, we are sending about 500,000 emails in 1 minute, right? So and we see many other units as well. But I think all of you are correct in the way that we're sending a lot of email. Next slide, please. So according to some search, and please feel free, we are sending 168 million email in 1 minute around the world. What my main point of this before I pass on to Dr. Rakmani is we are using a lot of data and we have a lot of data. What if we try to tap part of those data in a way that can help us answer policy questions? So next slide, please. So our question is, using the data we already have, who are the high cost user? And what are their common characteristics? What are the common diagnoses? And more importantly, what are some predictors that can help us identify who they are? Next slide, please. So here's a quick review on the method. We use 5 years worth of data. Overall, there's around 22 million records that we analyze. Next slide, please. So what do we find? On your left-hand side, you see that represent 100% of the people who have been hospitalized or who have used hospital admission. Now, what we found was that if you look at the 1%, okay, so the red color, 1% of those people, the top 1%, they are using almost 20%. So 16, 17, 18% of expenditure. But if you want to look at the high cost user that we define to be the top 5%, so you look combined between the orange color and the red color. And what you find is the top 5% of people who are hospitalized, they are using up almost 50% of all expenditure. Sure, there are going to be people who need frequent visits, but do all of them? So let's learn a little bit more about who they are. With that, I'd like to pass to Dr. Rakmani.
Thank you, Dr. Warandi, for your nice presentation. Now, I'm going to show you who were the high cost user. Next, please. Next, please. Okay. Over 5-year period, high cost users were male and older compared to low cost users who were female and younger. And almost half of total hospital costs was used by high cost users, which means that only 5% of inpatient use total hospital cost equal to around 90% of inpatient. And the average cost for high cost user was around 100,000 baht per year, compared to only 3,000 for low cost user. Next, please. So what are common diagnoses among high cost users? Next, please. We found that among high cost users, the most frequent diagnoses include neoplasm or cancer, disease of circulatory system, and respiratory system, which consume more than half of annual expenditure. Next, please. So, can we predict the next high-cost user? Next, please. We use multivariate logistic regression model to examine the potential predictor of being and high-cost user, and we found that age, gender, type and zone of hospital admission, disease, and morbidity, number of visits, and mortality were all associated with becoming high-cost user. And all these variables were statistically significant. Next, please. So, to conclude, the high-cost user tend exist in Thailand, and that is the majority of inpatient care spending is concentrated in the top 5% of hospitalized population. Our findings about high-cost user appear to very similar to those reported in the international literature review. Next, please. Next, please. This study highlights many strengths and limitations for the future research. This is the first study to confirm this trend of high-cost user in Thailand. We think this study could be applicable to our setting in low middle income country, and having such information can help us respond concludingly. This is also an example for how existing admin database could be used to answer policy relevant questions. For example, knowing who the high-cost users are could help us monitor the magnitude and trend of high-cost users and help develop relevant policy, such as universal health coverage reimbursement policy, reduce additional cost by high-cost user, or improve health outcome from high-cost intervention. Moreover, this finding could prevent future high-cost users through prevention and promotion program, and better healthcare management system. However, this study includes only direct healthcare costs and does not consider other types of health services. And like any other study, we also have some data limitation for example, missing data. Finally, on the positive note, we are continuing to work with national policy maker to apply our findings on high-cost user and support the healthcare system. Next, please. So, thank you for having me here today, and for more information, please scan this QR code or visit our website and at HITAP.net. Thank you.
Thank you.
Thank you so much, Dr. Wanrudi and Dr. Rukmani. I think that was a fascinating presentation. I think that, you know, it points a way to us, as Dr. Suwit says, not just, you know, using information and knowledge for the past, but, you know, trying to make sure that we use information and evidence for the future, and therefore being wise and having wisdom. I think also maybe one of the things that, you know, that this study points to is the possibilities, you know, of having healthcare systems respond better, but also other considerations in terms of the use of data. I mean, I think that's also another issue that we may want to consider. So as Aparna has said, you know, it's almost 2 hours, but we've got a couple of, I think about 20 minutes more that we can usefully use to have a panel discussion and also to get to the questions that you have for us. But I think what we would like to do is to get things started. I know that the chat box has been very active, and I think the speakers have also been responding to them. What I'd like to do is perhaps start us off with a question. Given that this webinar series is about knowledge exchange in the time of COVID, we thought that one question that we could put to all of you, not just the speakers, but all of you, is that with the impacts of COVID-19 across, you know, being felt across the health systems, what do you think are the major lessons that we've learned about ensuring uninterrupted health services? And this, for example, we've talked about immunization systems, you know, PCV, but also ensuring continued care for patients, and including cancer patients. And related to this question is, how important is the use of evidence in decision-making during these times? You know, obviously the pandemic being, you know, foremost on our minds. And to kick us off in terms of a response to this question, we've taken the opportunity of inviting a speaker to do just this. And we're going to invite Dr. Shankar Prinja. And let me just give you a very quick introduction to Dr. Shankar. He's an additional professor of health economics at the PGI-MER School of Public Health. You can see that on the screen there. And he's a doctor, medical doctor, specializing in community medicine and public health. He's also a member of different advisory groups in India, and I will not list all of them, but just to say that, you know, he is a member of the Prime Minister's Economic Advisory Council on Investment in Human Resources and Infrastructure, as well as converging healthcare and social security financing platforms. And I think he's very well qualified to take us to you know, the first response to this question. So let me invite Dr. Shankar to take the floor to respond to this question. Dr. Shankar, the floor is yours.
Sure. Thank you very much, Cecilia. Can we have the next slide, please? Sure, thank you. So as the COVID pandemic, you know, spread across different countries, while there was a lot of attention on trying to mitigate the COVID-19 cases and build up a resilient response towards that, but at the same time, there were initial reports that were coming in to say that there are negative externalities of the COVID-19 on some of the other non-COVID health conditions. And there were a range of factors that influenced that, factors that were on the demand side, and there were factors on the supply side. So on the demand side, there were access restrictions being put on place because of lockdowns, which placed geographical barriers for people to come to and visit health facilities. And then there was a public perception where people were sort of reluctant to go to health facilities because there was a perception that there might be risk of getting greater exposure to COVID. And then there was also an economic downturn that was taking place, people, you know, getting off the jobs, and as a result, there was a loss of income, which ultimately affected their ability to access healthcare services. And that's specifically in those country contexts where access to healthcare is largely dependent on the ability to pay, because these are largely financed through out-of-pocket expenditures. And then there was a supply side story that was going on alongside, where there was a diversion of the limited available resources towards the COVID-19 response. And as a result, hospital beds, ventilators, ICU beds, they were being made available specifically for the patients who were with COVID-19. And so these were designated as COVID hospitals, and these were not now being used for a lot of other services. And there were perceptions within the healthcare workers as well, who were more susceptible to infections, not to get close to or try and encourage patients with other kinds of diseases to come to the hospitals. And together, both of these demand and supply side factors ultimately led to a reduction in both the demand and supply for non-COVID health conditions. And this ultimately resulted in an impact on the utilization of these services. So next slide. So we particularly first tried looking at the impact that it had on primary care services. And this was specifically in the context of one of the North Indian states where we were working more closely. And this was the state of Punjab, which is in the north part of India. And what we found was that immediately during the period of lockdown, except for services which were family planning services, which were delivered much more through a village level healthcare worker who was accessible at that point, rest all services in a different graded levels, they got impacted. And the ones that I show in the red color are the ones that were hit the most. And these were immunization, the follow-up care for chronic diseases like diabetes and like hypertension, and the services for malaria control as well. These were the ones that got impacted the most. And then there were others like the reproductive health services for the pregnant women, children, etc., that also got affected by moderate extent. And as you can see in the next, the right side of the slide, where after the lockdowns were lifted, immediately there was a realization that during the periods of lockdown, immunization, vaccination for children had gone down. And as a result, immediately the program managers realized this, looking at this evidence, and they immediately made an attempt to try and boost up or organize some kind of catch-up campaigns in order to make up for the loss of the days and the vaccination shots that were missed during the periods of lockdown. Next. And then the other piece that we tried looking at was that for chronic diseases, which required a much more prolonged contact with the healthcare services, what has been the impact on such kinds of services? And the one that we picked up particularly was cancer, where we tried looking at in one of the large tertiary care hospitals, again in the north part of India, is that as a result of the COVID, what has been the impact of COVID on the provision of outpatient care for cancer and the provision of services for treatment, specifically the radiation therapy. And you can look at the graph and you can see that there is a kind of it goes like a horizontal graph till you are in the middle of March or towards the end of March. And then suddenly, both for the outpatient care and for the radiation therapy as well, there is a sharp decline that goes there. And that's exactly the point when the national level lockdowns were put in place and there were geographical barriers to accessing services. And so these patients of cancer could not actually travel and could not reach to health facilities. And that's also because the way the care for cancer is organized, where it is generally available only in large tertiary care hospitals that are located within bigger cities. And people from the rural area have to travel to these cities to get the care. So there was a significant sharp decline during this period. And then moving on to the next slide, please. We tried relating that with this reduction in the access to treatment, so chemotherapy is getting delayed, the provision of surgery is getting delayed. Surgery was one of the biggest hit that was affected at the time when the COVID lockdowns were put in place. So we tried modeling the long-term impact of this delayed treatment to patients with cancer, specifically for cervical cancer. And this was only within cervical cancer that we were looking at. And we tried modeling long-term outcomes in terms of what would be the excess mortality and disability adjusted life years on specifically for cervical cancer. And we tried looking at for different durations of lockdown, for just a small duration where the lockdown was much more intense, which was for 9 weeks. And then there was a graded reduction in the restrictions that were put in place for the next 3 weeks, which went up to 12 weeks. And then it's been almost about 6 months now, although the restrictions have largely gone off now, especially for provision of these services. And we saw that there were significant excess deaths and life years and disability adjusted life years that we see that are lost because of the kind of restrictions that were put in place. So next slide, please. So ultimately, this leads us to a situation where we need to realize that such situations, such pandemics, not only need us to put up a response to mitigation of these pandemics, but also we need to build systems of healthcare that are resilient to meet such eventualities. And we need to sort of change the rules of priority setting. And in this particular case, when we were looking at the cancer and we discussed these issues with the clinicians who were actually providing care, it was immediately felt that perhaps the treatment guidelines could be sort of reoriented and reorganized such that if surgeries are what are getting delayed, at least the onset of radiation therapy where there is a lesser chances or lesser restrictions in terms of provision of care could be something that could be started. Or maybe those kinds of chemotherapy that could be given on which do not require hospitalization, those could be started. So there were changes that were made in clinical pathways for provision of care. And also there was immediately an introduction of telemedicine services that were put in place for such patients who required chronic care, who required long-term care. And the importance of continuation of primary care was again felt immediately after the provision of this kind of an evidence. And there was immediate reinitiation of immunization services for family planning, and for antenatal and postnatal care. So thank you very much. I think this was my last slide that I wanted to talk about.
Thank you so much, Dr. Shankar. I think that was, obviously very interesting. I think this is the situation that many of our countries are facing, not just in terms of addressing and responding to COVID-19, but also looking at how we can mitigate the impact of COVID-19 and the pandemic across the health systems. And I think, what you're saying is to look at how we can reorganize the priority setting, as well as, figuring out the different options that will help us ensure that we don't neglect other diseases, that we mitigate as much as we can the impact of COVID on everybody else. So that's wonderful. Thank you so much. Please, any questions for Dr. Shankar, on the chat box, please. But I'd also like to, re-invite our other speakers to remind you that it's Mrs. Deepika Adhikari, it's Ms. Jamaica Briones, Dr. Rukmani, and Dr. Wandrudi, and yourself, Dr. Shankar, who are on this panel. If there are other questions from the audience for this panel, and Dr. Alia as well, let me not forget you, please put them on the chat box. But perhaps I could also invite the panel now, if they also have a response to this question that we've just asked. Maybe I will repeat the question again. The fact that the COVID-19 has had an impact across our, all our health systems. What are the major lessons that, we've learned about ensuring uninterrupted health services? And of course, the use of evidence in this decision-making processes. Would anyone from the panel like to take this question and respond to it? I will look for raised hands as per typical. And I also encourage the audience to put in more questions for the panel. It's been a long session, but a very interesting one. Is there anyone who would like to respond, but also maybe we'll look at other questions that have come in. I think we've got one question that's just come in, and it's on the chat box, I believe, from Dr. Abebe Bitu. And the question is, given that the lockdowns have taken the first options for prevention of COVID-19, most of the services other than health services misbehaved in their services, for example, transport, supermarkets, and even politics. What is the suggestion, to address these challenges? And, do you think that there are lessons that we can take from these? Anyone from our panel who would like to take a shot at these questions, and also maybe share some experience from your countries in terms of how these were dealt with or addressed?
Hi, Cecilia. Can you hear us?
Yes, indeed.
Hi. So certainly I don't have the answer, but if it's okay, I perhaps a thought to follow up. I think this is a very important and great question. Something that perhaps I could share was when you're talking about major lesson learned and what we can do to help with the next stage. I mean, all of us know that COVID-19 is in many ways here to stay. Not that we want, but or at least for a while, right? So something that we came across that I think is the framework that guide our response in Thailand is around the concept that we call co-production of knowledge. And it has 4 components. The first one is about being context-based. Second is pluralistic, engaging with many stakeholders. Third is around being goal-oriented, and last is around being interactive. So during the past few months, I think our many teams, many sectors in Thailand have worked together and trying to understand the problems in your own context. I think it's key because every country is unique. Second is engaging with all relevant stakeholders from different sectors in this case as well. And so I think having this co-production of knowledge framework in mind, it helps us review, find, create evidence that we then pass on to policymakers at the Ministry of Public Health and HITAP along with other research institutes such as the International Health Policy Program or Health or HPP. We also part of the group who help generate evidence. So I just want to share that I think keeping in mind that, at the end of the day, collaboration is key. That could be something to a good takeaway as well. Thank you.
Thanks so much, Dr. Wanrudi. Dr. Shankar, was that a finger of a hand up?
Yeah.
Please, go ahead.
I couldn't find the hand signal up there in the WhatsApp, so I just thought I'll just raise my hand as well. So please. I think that one of the other things that that this COVID pandemic has brought to our attention is that all of us who had been working in health had always been trying to advocate for a greater political will, and we've been trying as much as possible to bring health into the political agenda. But what COVID-19 did was that it actually also not just brought health into the political agenda, but to large extent greatly politicized health as well, which was something that was never experienced before, and which meant that the communication of evidence also became a very, very important point. And communication of evidence for all kinds of things. It's not just health, but it's also issues around the kind of issues that, for example, Abebe had raised, that mentioned about the impact that COVID has had on other services, and the role that communication plays and the communication of evidence plays also places an importance on how we engage with the media as well. So I think I just wanted to raise these 2 points about how you engage with media on communication of evidence, which became the disseminator of evidence even before you had the evidence in a peer-reviewed publication form. So the media was the first one to actually raise the evidence in the open domain. Thank you.
Absolutely, I think those are very important and valid points, Dr. Shankar. Thank you so much. Yes. Sorry,
I would like to add,
please.
Yes,
please.
I would like to add to what Dr. Wanrudi talked about collaboration, and what Dr. Shankar also talked about, communication. So in the case of HPV in Bhutan, these two, communication and collaboration, played a huge role, because earlier in our regular method of giving out vaccines to the girls in the schools, we always did the formal approach. That means we wrote letters and we just showed up at the schools to vaccinate the girls. But this time we collaborated with the Ministry of Education to reach out to the girls. And at the same time, we used various ways of communication, like we used social media, messenger apps like WhatsApp and WeChat groups to reach out to the girls. So these two were really crucial in meeting our target of over 95%. Had we done the same thing even in our regular days, maybe we could have also tried to reach 100% coverage. That's what I would like to emphasize on. Thank you.
Fantastic. Thank you so much, Deepika. And I think also the question that Abebe had raised, Martha from Ghana has also said that it is actually important to be looking at the whole of government response and that all agencies have a role. I think that's another valid point. But maybe one final question. I know we're running out of time as we do, but I think there is a question from Melissa Guerrero, who wants to ask if there has been shifts in the priorities of HTA agencies in the countries that we have represented here. She says that, you know, this is the current experience in the Philippines, and that, you know, the work is now very much focused on evaluating COVID-19 health technologies. Now, maybe a very quick, you know, sort of round from the panelists, yes, no, and how has that changed? Maybe I'll start with Dr. Shankar and then go to Dr. Wanrudi.
Yes, absolutely. I think in India as well, a lot of those who were earlier part of the kind of HTA body and HTA secretariat were actually moved towards the working groups that were specifically looking at the response to the COVID. So absolute yes to this question.
Thank you. Yes, and Dr. Wanrudi and Dr. Rukmani in Thailand?
Yes, another yes, I'll second the yes. Yeah, and I don't think it's just the health sector. I think it's all sector. I think the national or even the global priority are shifted just to respond to this pandemic. I think from the HTA perspective, our goal or purpose remain the same, which is what can we do to help or assist policymaker in making the decision, but this time in a very, very timely manner. So sometimes decisions have to be made that we have less than 24 hours. So we gather information and talk to email. I know we email Dr. Shankar, what is India doing, who is doing what, and I know we email Dr. Melissa a few times as well. Like, so I think at the end of the day, I think we're stronger in strength if we stay together. So hope everybody continue to stay safe. Thank you.
Thank you so much. Again, very well put. I'd like to see if Deepika, you'd also want to, you know, chime in from Bhutan.
Yes, it's the same case even in Bhutan. All our work is right now focused on evaluating COVID-19 related technologies. We have kept other activities on halt for now due to the pandemic.
Yeah, thank you, Deepika. Dr. Aulia?
Yes, thank you. So the same situation in Indonesia. At this moment, all stakeholders are putting COVID-19 intervention as the top priority. But in terms of immunization programs, I think it's also critical to maintain the performance of routine immunization program, because before the pandemic, the situation in Indonesia, the coverage of basic immunization program tends to be declining. So the challenge before the pandemic, there is a serious issue regarding vaccine hesitancy. So I think at this moment we are facing two big major problems for mitigating the pandemic and also for maintaining the performance of basic immunization program.
Thank you, Dr. Alia. Folks, it's up to the 2 hours, but I think we noticed that we have, you know, most of our participants here. So I think we might take the opportunity of, you know, further engaging with all of you. And I think there was a follow-up question from Les Ong. In terms of, you know, yes, we've all said that, you know, obviously the priorities have shifted because of the pandemic. But I think, you know, and obviously everyone's kind of focused on, you know, COVID-19 health technologies. But Les's question is really, you know, what are the implications on non-COVID related HTA work, and, you know, what's been the impact? So maybe I'll go back to our panel members. What's been an impact, and also what's been done, and what are the lessons learned from this? How do we maximize our scarce resources at this time?
In the case of Bhutan, for the non-HTA work, what we have done is we have made a package of essential health services that are being delivered even during the pandemic. So focus is all upon the essential health services that are being delivered right now, other than health technology assessment related work.
Great, thank you, Deepika. Do I
hi.
have? Yes, Jamaica.
Hi, this is Jamaica. Yeah, but catching up with us today is the Director for HTA Unit and DOH Philippines, Dr. Melissa Guerrero. And I think there's no better person to give us that answer. So, hi, Doc Meme. Okay.
Hello, Jam. So,
yes.
Yes, I'm not a panel speaker, but
yes.
How has it affected the non-HTA or the non-COVID-19 priorities in the Philippines? Obviously, so similar to the other experiences of our neighbor country. So the other disease priorities have been a casualty. So like we didn't do immunization for the past 2 quarters, and we have disrupted health services for non-communicable diseases, family planning program, and it's only now that we're catching up. But obviously on top of this, we still have to continue the pandemic response, because as currently known, so the Philippines is among the heavily affected countries by this pandemic. I think we're #1 in the Western Pacific region in terms of cumulative cases and the daily new cases. So it's really challenging. So that's why I asked, because I think we can collaborate in terms of sharing our experiences and how we do the generation of evidence to inform our governments on what response they should take. So for example, now the HTA Council, so we just produce our own process and methods guide, but largely that has not really been the path on how we produce the rapid reviews and produce the recommendations for our government. Obviously, everything is being done rapidly, and there's hardly no consultation. Mostly we are doing rapid reviews so that we have the timeline and produce the recommendations that are needed in the pandemic response. So it's really challenging. So I could imagine India also having a very challenging situation because you have also a lot of cases there.
Thank you so much, Dr. Guerrero. I think, you know, as you well put it, this is something that we are all faced with. It's a great challenge. But I think it's also, both you and Dr. Wanrudi has said, it is about collaboration, because this is possibly the one time where, you know, sort of partnership and collaboration and exchange of information and country experience is, you know, more important than ever, just because we have such short response time, you know, that, you know, we do need to make sure that we are all able to share as much as possible. And I think this is really the point of this webinar series, that we felt that there was a need. We are all, each of us in our countries, trying to address and mitigate and deal with the pandemic, as well as everything else within our health systems. And we felt that it was extremely important that we're able to share the various lessons, not just the successes, but also, you know, in terms of where things may not have worked as well. It's the idea of making sure that, you know, people don't repeat, or they don't have to repeat the failures. So this, I believe, is, you know, the sort of overarching aim of this webinar series. I know again that we're, you know, running out of time, but I do believe that this has been a wonderful, you know, sort of series, and this particular webinar is one where I think we've got a whole series of lessons. And I know now that the organizers of this webinar is asking me to do a 60-second summary of what we've all learned. I will never be able to do this justice, but I thought maybe 3 points that, you know, that may come to mind. Obviously, we know the use of evidence is very important. But to be able to use evidence, I think, you know, we are clear that we need to have systems in place that we will be able to gather the evidence and the data to monitor this, so that that then informs the decision-making process. The second point is, on top of the systems for gathering data and evidence, I think it's the governance structure that we want to have in place that will enable our HTA researchers and so on to ensure that whatever evidence that they find and whatever evidence that they feel is important is then, you know, taken up, you know, to guide and to inform the policy decisions. And I think that, again, is the second key point. And then thirdly, I think that's also been mentioned already, which is the communication of, you know, the evidence as well as the findings. I think that is clearly a key component in making sure that we're able not just to use the evidence, but to ensure that there is acceptance of the findings, and then eventually there is acceptance of the policy decisions that are based on this evidence. So I hope that those were the three, I suppose, key takeaway messages that I have, you know, from this very instructive webinar. As I said, I will not pretend to do justice to the depth and the richness of the information that we have got from here. But perhaps just to say that we, as has been shown in the Menti poll, we would like to continue our discussions. We know that it's needed. So for the first instance, what we're going to do is to ensure that everyone has access to all the presentations, all the resources, and, you know, materials that have been discussed, talked about, and passed on. So these will be available in the websites of ADP as well as HITAP. And then I think we also welcome your suggestions and proposals in terms of what would be useful for you in the work that you're doing in your individual countries. So what we will do would be to keep the discussion and the communication line open through our websites, but also we will be reaching out to all of you via email, just in terms of, you know, sort of updating each other and, you know, sort of, again, you know, finding ways and means of collaborating. So 10 past the hour, I think this is a good time to wrap up. I would like to, first of all, thank our wonderful speakers, from Dr. Seward, who has unfortunately you know, left to go to yet another meeting, but to also all our speakers, Deepika, Jamaica, Dr. Aulia, Dr. Wanrudi, Dr. Rahmani, and Dr. Shankar. I hope I haven't missed out anybody else. And then also, you know, my thanks to the HITAP team who have been working tirelessly, you know, behind the scenes, as well as my ADP colleagues who have also been part of this, you know, sort of planning of this webinar. So thank you. And then not least, to all of you, the participants and the audience of this webinar, not just this one, but the webinar series. Thank you again. We've all learned from each other. I think that's safe to say. So let me then close by handing the floor over to my HITAP colleagues who will show you where you can reach us next and where you'll be able to find this useful repository of information and materials. So thank you, everyone, and you'll see the website. Have a great day or evening or afternoon, wherever you are, and we will continue to be in touch. Thank you very much. Over to you, Aparna.
Thanks, Cecilia. I think I have my colleague Alia who will show us the page where all of the materials are. Then we also would really value your feedback. We love to improve our material and make sure that the next time around we're able to give you more of what you're looking for and also keep the collaboration going like we've heard today. So I think here's our little QR code. If you can just scan it and give us your feedback, I promise you it doesn't take too long. We've tried to keep it really short. And also, as you saw, there's a link on this presentation as well about where the materials will be available. And I think we should have it for you in the next couple of weeks. And 1 and 2 are already available, sessions 1 and 2. Thank you very much for joining us. And I think thank you to Cecilia. Thank you to our speakers. Thanks just so much for taking time to be with us. We really enjoyed having you. And thank you to my team and also the ADP team for everything. Thanks, guys. Have a good evening.
Thank you very much. Everyone, take care.